that will allow you to log back in. This recording will be available and posted to the MHCC website. Please contact Christine Karanopoulos or send a chat message if you're having technical issues. She's going to add her information into the chat at this time. Since there are a lot of people at this meeting, we'd like to sequence speakers when possible. Please signal to the team if you'd like to speak by pressing the raise hand button in the reactions menu at the bottom of the screen and announce yourself when called upon by the facilitator to speak. You may also use the chat function to send message to specific attendees or all attendees. Additionally, the meeting facilitator may call on people to speak to ensure we have a wide range of perspectives. Workgroup members may unmute by using the small button at the bottom left of your screen. We do ask that everyone stays on mute during the meeting to try to keep it as quiet as possible. During the meeting today, we're going to discuss the pilot use case that the workgroup members helped develop during the last meeting. So at this time, I'll turn it back over to David.
Wonderful. Thank you, Melanie, and good afternoon, everyone. It's great to see so many of you on a Friday afternoon. It looks like those I can see are still bundled up quite a bit. So if it's cold where you're at, that's probably why. Although here locally, we're supposed to have temps near 70 this weekend. So we may all end up with sunburn next time we see each other. We want to get started a little bit talking about the use case that we worked on. Can we cast the draft pilot use case and Annie to the screen? If you'll recall, at our last meeting, we worked with you all specifically to identify what might be some key components of a use case. And today, what we really want to focus on is the use case structure that was developed with input from the providers, from the networks, and CRISP and others that are on the call today. We will make changes as we go through it. Just to kind of reiterate where we see ourselves going is what we structured here is an output of a conversation that will frame data elements that would be received by the state designated HIE CRISP as the requirements set forth in chapters 790 and 791 of the 2021 laws of Maryland. And what we were trying to do was be able to test the flow of information with electronic health networks as well as with CRISP. The actual use case itself, we may vary, and there may be many of them, but what we wanted to do is to frame it out enough where there can be some data that begins to move between an electronic health network or two, and with CRISP that can be examined for potential uses to augment other use cases that are occurring within the state designated HIE to support clinical purposes or public health, as well as for innovative thinking around additional use cases with the provider community. Today, the use case that's being proposed, it makes use of a HIPAA limited data set, which is permissible for exchanging information under the federal regulations. We did not want to go into a data set that with identifiable information based upon some of the feedback we received from participants at the last meeting. It seemed a better process to test the workflow and test the data flow before we get into too many granular aspects of a use case. So that's where we got to in terms of between the last meeting and this meeting. And we're hoping that we can work through these data elements and then discuss how the flow of data might look between electronic health networks and CRISP. And then after that, talk a little bit about how we can proceed down a pathway to test. And if we can accomplish all that in less than an hour, we will have an early start to our Friday afternoon. We've scheduled the meeting for 90 minutes, but we don't necessarily anticipate it'll last that long. why don't we start by walking through the elements? And I'm just going to turn it back to Melanie for a moment while I shut the door. There's some just a bit of noise out here.
As David was saying, this is the public use case, which is diabetes type 2. And at the top we have the approach, which was what David just outlined. So under the data elements, what you'll see is the first one is the ICD-10 codes. So these are codes that we pull that are codes that are commonly used to identify diabetes type 2 or to identify the complications with diabetes type 2. David, did you want to take it back?
Yeah, sure. So from the provider perspective, I think we are fairly limited in terms of providers that are joining. If there is anyone that wishes to weigh in on the data elements that are being proposed for the type 2 use case here, please jump in. If you'll recall, what we wanted to do was pick a use case that supported the SIHIS, the state's efforts here to push forward with public health initiatives that were approved by CMMI under the total cost of care model. So we picked working with the providers, specifically these data elements. And I see we have Dr. Kinder on the call, so that's fantastic. Hey there, Dr. Kinder, can you react? Do you believe that these data elements would be sufficient enough for us to be able to test the flow of data on type 2 diabetes, or would you say there are other ICD-10 codes, either more or less, that we should consider here?
If you use these as the parent code, right? Like, because there's 11, for example, 11.13, 8.14, et cetera, then probably that's going to capture most of them. Those CPTs may be drawn on people without diabetes on the other side, but
so Dr. Kinder, we would use these specific ICD-10 codes and these corresponding CPT codes. And that seems, in your viewpoint, a sufficient way to start testing for the type 2 diabetes.
Yeah, I think that seems reasonable.
Okay. Thank you, Dr. Kinder. It's always great to have you take part in these conversations. Anyone else wish to weigh in on the ICD and CPT codes? A couple folks, I think I saw both hands go up together, but let me just start with Mike. Welcome, good afternoon. Your thoughts?
Thank you. I do think that it's a pretty comprehensive set of ICD codes for diabetes. I was wondering if we could maybe circle back to the providers to define the actual use case we're trying to solve here. I mean, this will give us diabetic claims, but what are we trying to actually accomplish with them? If it's just to test the passing data back and forth, that's wonderful. This will do that. But if it's to actually fulfill a use case, we would probably want to define that beyond, can we move diabetic data back and forth?
Yeah, and I'm happy to jump in, and then others can. So, Mike, it's a little bit of a chicken and the egg kind of reaction. The thinking here is, do you develop the use case and then build the data to it, or do you develop the data flow and then build a use case around it with some innovative thinking? And we've kind of waxed and waned a little bit. And in talking to the providers, what there seemed to be a good sense of is that we look to see how we can use administrative healthcare transactions to effectively do more around type 2 diabetes use cases for public health, particularly in a limited data set purpose. So what we said is we would get some data points that we could test the flow of information outbound of an electronic health network and inbound and ingestion by CRISP. And once we could begin to solve for those two challenges, then we would, during the sort of at the same parallel time, look at how we can make the use cases make use cases that would support that data, and consider how it can be provide more use to the care delivery, or into the study of research, or epidemiology work with the department. Okay. So does that help? It's a long-winded answer, but I hope that gives you a sense.
Yeah, we can dig a lot of value out of any sort of exchange. So I can think of a bunch of things we could do with this as proof of concept on data exchange.
Yeah. Outstanding. Wonderful. Thank you. Angela, good afternoon.
Good afternoon. Can you hear me?
Sure.
Great. Thanks. I appreciate, Mike, you're stepping back, because I think that's sort of where I was coming from to understand the use case a bit more. I don't really have a reaction to the specific ICD-10 codes. But in the pilot program you're envisioning, would this data be redisclosed to public health authorities? To who? That's my first question. And then would this limited data set only include a subset of individuals within the state, or would it be everyone? So I think just putting some parameters around what's the use cases can be helpful, and what's going to be helpful for the pilot, since it's just sort of a test here.
Yeah, and those are good points. Thanks, Angela. At the moment, what we're talking about is as a public health use case, and we think there's some need to really dig into the data elements and how much data, and I think we're going to get to that momentarily. So what I would say is, it hinges a little bit on where the filtering who does the filtering of the data. Is it the networks that extrapolate the limited data set, or do they push a large number of, say, an 837 Ps to CRISP, and then CRISP filters out for a limited data set? So I think that's a little bit more what we want to talk about in a few moments, but those are good questions to start putting in the minds of the participants.
And then the second question about who would receive the data under the pilot?
So at this point, it would be strictly limited to CRISP, because what we want to do is test data flow and look at what kind of innovations can be developed around how the data can be used for public health. We still need to have more conversations with the provider community, and some of it will hinge upon what CRISP is able to do in terms of ingesting the data. So at this stage, it's really, to go back to what Mike said, it's testing data flow, it's getting it started and testing it. So as opposed to getting it started, testing it, and then putting it into a specific use case. We focused on a use case around clinical care for diabetes as a way to test the data flow, but we could have used a different use case, but it just seemed that this was more of an interest to the providers, that hopefully more will come, if you will, as it relates to the diabetes use case. Okay, other reactions to the approach so far that we've talked about? So let's scroll down a little bit, Nady, and go into what we see next. So what we're thinking of in terms of data elements, the file would be, we would focus on the 837P from the network side. And if you could scroll down just a little bit more, we would be looking at select provider types coming out of the 837, and specific information related to location as well as zip code, again, for testing purposes. So we want to move into talking a little bit about how the data can be extrapolated from the administrative transaction. And this gets back to the network side of the equation. We would want to see how the administrative networks could pull together a limited data set that could be sent to CRISP for testing. So I think, Angela, I believe you are the only network that has joined us for today. Is there someone else from an electronic health network on a dial-in phone number that I've missed?
I did let Murray know from Expedient, but I don't know if anybody else from the network's got an invite.
Melanie, I believe, reached out to Murray, but I don't know if
I don't know for sure if he's gonna attend. We gave him the information for the call. He said he was gonna try. Someone just called him a phone number, so I'm not sure who that is.
Somebody from Availity? No.
That's it. So, Angela, are you able to talk to us a little bit about how Change Healthcare might be able to pull together a file that we do have Kathy from Availity. So, Kathy, we're going to come to you just in a moment. Angela, are you able to speak to that today? Or?
Not to the technical approach to it. I think, Change Healthcare still has the policy business associate agreement considerations when it comes to, even before we jump into the technical approach, and I can speak to those, but not specifically to technical. Mike Dennison wasn't able to join the call today.
Okay. Kathy, your thoughts? Okay. Kathy's sites, you may be on mute.
Okay, so I mean, we still have the issues that are open that we've proposed from the cooperative exchange, but I think what it is we would really need to get to when we talk about the requirements here. So, I mean, are we talking all payers, which payers, the patient information, opt-in issues. So there's still a lot of open items, but I mean, so we already have we'd have to establish connectivity once we get through all of the other prerequisites in order to get to the data.
So if we're using a limited data set and it's been de-identified, help me understand where there might be challenges for Kathy, for you all.
For us, I mean, it would actually, that's why I say the requirements would be needed to be able to identify all this stuff as far as is the stuff that we can pull from a database, and what the requirements are to identify the select grouping. Do we do something by zip code? Is it by state? Is it by certain payers? Is it have to be all of the above in order? That's why I say we need a specific set of requirements in order to be able to pull the actual data. I mean, so we've got ICD-10 and CPT codes. What's our date ranges? There's several other requirements that we would need in order to be able to pull the subset and then de-identified data.
So would it be helpful if we work through an 837P and identified particular areas of the 837P and what information we would be looking for from the network to be able to create a test file?
I would think that would assist in the full-blown requirements. Yes, I mean, do we look at the let's talk about Aetna.
Okay.
As a national payer. Mm-hmm. Do we zero in on certain the provider zip code, the patient zip code, the patient state code, the provider state code? How do we pull the data that you are going to be requesting?
So if we were, and that may be where the specifications of the data dictionary for an 837 would come into play, because if we said some of the differentiators, for example, where if it's a Maryland-based provider, in terms of being able to test, if they're located in Maryland and they submit a claim, in this case for diabetes, and we would want the certain de-identified elements, which I believe is in the second document that came along with the meeting materials for today. And we'd want to be able to test these coming outbound for Maryland-based providers. And if we do Maryland-based providers, that would be the test bed, if you will. And then we would want to work with CRISP in order for CRISP to be able to receive those data elements and be able to take them through their technology solution to a point of which they could be used in a public health utility format. Does that help a little bit, Kathy?
Yes, it does. So what about the patient? What if I'm an out-of-state patient seeing a Maryland provider? Is that data part of this request?
Well, we are able to use zip code in the de-identified file. So we could select a range of zip codes that were unique to a Maryland county at the county level or the city level of Baltimore to test with. So I think, again, we would stick to the limited data set that's permissible under HIPAA. So we can sort of skirt around issues related to using data that would require patients to have knowledge, or rather to have a consent to using it for some other purpose. And this would be permissible. This is what's permissible under HIPAA. So we would be working with the network and CRISP to make sure that we stay within that compliance range. And going back to what Mike suggested or said at the very beginning, what we're trying to do is test a proof of concept with data flowing from an administrative network, and specifically in 837, to CRISP to really ferret out the challenges in just the data exchange component, using a use case that would have elements of relevance to public health, this being the diabetes type 2. So Craig or Mike, can you talk a little bit about what you would foresee being required of an administrative network in order to be able to start receiving data, administrative transaction data?
Sure, I can go unless Craig, you want to jump in?
I will start, but you're gonna have to do all the heavy lifting.
Okay.
As usual. So first, I appreciate kind of David, you bring this group together. Ideally, we have a lot of use cases we want to get to, but the approach to be incremental, to try and move some data before we move all data, makes a lot of sense to me. It's a nice way to get our tech teams familiar with each other. It's a good way to kind of work through some of the policy without doing policy entirely before the tech is even thought about. So appreciate kind of the approach, and I'm glad that we can be part of it. I think for the most part, we can be pretty flexible on kind of the data and how it's transferred. I think my preference would be to start as close to the final kind of end game as possible. So for example, if EHN's already had some of the more timely transfer mechanisms in place that we could use for this use case, APIs would be wonderful, but certainly if we could do kind of HL7 transactions, that would be great. We would also be willing to do more on our end if it would help the EHNs to do less on their side. And we can talk through exactly what that might be. If in order to launch the use case, we instead just looked at a kind of bulk file that we put into a data lake to produce some, to essentially test some outputs that wouldn't be shared, as you said. We could go down that road first, but I think I'd prefer to explore kind of existing, transfer mechanisms if we could. But Mike, if you want to elaborate or correct anything I just said, please feel free.
No, I think I just mostly just echo it as starting as close to the end as possible. So, if down the road it's envisioned we get a complete 837p for, well, just a complete 837p, I'd like to get a complete 837p today with missing fields. So and that way the infrastructure we build on our end doesn't have to change; it just becomes more populated. Likewise, as opposed to sort of batch data or bulk data. I'd like to think, like, if there's a diabetic use case and we got a diabetic claim in, maybe there's a point where we can reach back out to the EHNs and pull other claims for that diabetic patient, since they won't all necessarily have a diabetic diagnosis. So we could work on functionality like that with data being close to the endpoint. I think that's it.
So
I'm excited to get some data. Go ahead, David.
Yeah, so I think what you're saying is that by starting the data flow, you're able to look at it, and this is would be able to spur innovation around use case development specifically, but getting some information moving between the two technology networks, the state designated HIE as well as the electronic health networks, would create that environment where there could be that deeper review of the information and how it could be used, again, to support the public health initiatives.
Yes, and also what I would like to avoid is getting some sort of lessons down data, making assumptions on what we could do for real and finding out we can't because we didn't, the real data didn't support it. The other thing I mentioned that Craig mentioned is that we are willing to do more here. If you look at whether the EHNs limit data they send to us, or we could conceivably build an API that limits the fields that it pulls. So we could have a single API that the EHNs could hit that would only pull the data in a limited data set. So I think there's several ways we could go around making it a lot easier on the EHNs while being compliant with the limited data set while we work out these other concerns we have.
Yeah, that's a great point. That's a great point. A couple hands raised, so let's take them in order. Angela, you want to make a point?
Sure, yes. I understand that we're sort of restricting this release to a limited data set because that doesn't require patient authorization. However, I'm not sure where the data use agreement would stand. At least my understanding with HIPAA is that the data use agreement would be between the covered entity and the other entity that's receiving that data. In this case, the clearinghouses are working with several covered entities when it comes to pulling this data. So can we talk a little bit about where the agreements are, the governance is?
So I'm not sure we're ready to do that today. I think because what I would say is that it may be splitting hairs. For example, clearinghouses are also covered entities, and so are the providers, and so it gets to be a little tricky depending upon which seat people sit in, and I'm not sure we really want to have that kind of conversation because I don't think there's really any answer. I mean, it's going to create a lot of what I would call probably. It just probably would create confusion or speculation. I think what we want to do is say, the policy issues are important, but I'm not sure we have to work through them in order to test data. I think they can be handled in parallel or in a different setting. But for the time being, I think we really want to be able to say, how do we make the data work? And then we'll figure out the policy components, because it's not that we would want to neglect them, but for purposes of testing data, I don't think they have to be resolved right away. And I'm not sure they actually could be, but right now we want to talk a little bit about how we can stay somewhat compliant with the Maryland law as we look to advance this, what I would call this specific de-identified use case, if you will. and this is more of a data initiative than right now that it is of the care delivery side.
And I think that would be fine if we're talking about dummy data or completely de-identified. I think a limited data set still has to adhere to certain requirements around federal policy that change would have to recognize.
Understood. Lee, your comment.
So I was just looking to clarify here with Mike and Craig. So what I'm seeing as far as the requirements, one is the first is really kind of creating this with a Fire API is one I'm looking at here, as well as the last one is to build a Fire API that would pull the filters. Is that what I'm seeing, and I'm just looking to make sure that I understand. And then the bulk file is really an X12 bulk file transfer is what I'm of either the 837p or the 837. So it was more clarification, David. I wanted to make sure that that was really what they were talking about.
Yeah, that's a good point. Mike or Craig?
Yeah, so I think what we meant is essentially that we would take the data in any existing transfer mechanisms you can provide today. We're not expecting you to build out custom APIs or to do anything like that. And if there was a rank order of what we would prefer, then I think it would be something closer to a real-time transmission method.
Yeah.
If APIs were available, we would certainly hit them. We would take HL7. If bulk file was kind of the quickest and only way to get a limited data set to us in order for this kind of first step in data transmission, then certainly we could work with a bulk file.
And Lee, based upon your experience, where do you think electronic health networks are best positioned in terms of being able to provide data in the way that's being proposed?
David, I would certainly hope that we're heading, I think as Craig was talking about, I mean, I think this provides, a good migration path. Certainly all of them can do X12 transactions today with the EHNs, as well as all the clearinghouse operations. They do that today all the time. But to me, I think the key that's where we're heading, whether or not it's with TEFCA and these QHINs that are going to be evolving, and the participants and sub-participants, as far as kind of that from an interoperable network, as well as other kind of EHN to EHN, I would hope that we're heading towards more of option 1 and 3 here, where we're leveraging a lot more of the Fire API capability to be able to do that. And including in that, leveraging, for example, the Unified Data Access Protocol, the UDAP protocol around not only authentication, but identification. That way, at least again, from a security perspective, that we're building in more secure transmission between those various EHNs as well. So there's, I think, a lot more, I guess, I would say, credence around moving or migrating to that of Fire APIs in the future.
Okay, well, that's very helpful. That's extremely helpful. So thank you for that. So let's talk a moment about how we might be able to use data to get things started, even if it's, I think, Angela, your point is dummy data. Maybe it doesn't have to be dummy data. It could be de-identified data. Kathy, if that's the preference, how would we get started down that pathway? And Angela, I'll just call on you to kick us off here.
In terms of what path, what step on the pathway? I think.
Yeah, so let's say we wanted to use fictitious data and be able to transmit that from Change Healthcare for the moment to CRISP. How would we proceed down that pathway? What would you need? What would
I think to Kathy's point is the requirements, the specifications in terms of who, what, when, where of the file and how it needs to be parsed out. The date range, is it a particular region? Is it which location for the provider? All of those specifics.
And that would be, Angela, to your point, taking the data dictionary of an 837P and carving out the elements that we'd want information in?
I think that would be an okay starting point.
Okay. And I think what I heard Mike saying was, even if there's no data, the position of which the 837P, the segment of it, it would all still pass through. It just may not have any data in it. I think, Mike, you're making that point so you can be able to understand how you would ingest that data.
Yes. Yeah, we get lots of missed fields on data we get today, but it's nice to have the formats correct.
Yeah. So I think we have I'd be curious from the payer's perspective, who works with data a lot, the 837. Can anyone speak to how you all test when you with the implementation guides that maybe Clay, you could talk to that. Is it a same sort of approach using the implementation guide that would be necessary to, is there any guidance that you can provide around what that file might look like?
Yes, our experience is that most places have an implementation guide that gets into the details of how within the standard you use specific fields and specific values and what's allowed and what's not allowed. And what we do for testing of that is, we have a point where we use synthetic data, and then beyond that, we take actual samples of real data and de-identify it by removing the identifier fields. And then we run large volumes of real production data through that way. And so it's a good point that this is going to have to look at the usage guides and the implementation guidelines of all the participants, because they are all a little bit different. But my guess is that most of the fields that I've been hearing discussed are fairly standard and not a whole lot of interpretation in those.
Well, you bring up sort of indirectly a question that comes to mind. Do the payers have these kind of, I'll call them shelved synthetic files that they hang on to for sending out to, if a new network wanted to onboard with you, that you would say, look, here's let's move this data file back and forth. And I say that because maybe we could be saving a step from the perspective of the networks. If there was something that existed and we were able to say to CRISP, here's what you need to build to.
Speaking for Care First, no, we don't have anything that we would be comfortable sharing because it's not in a fully de-identified manner. We do obfuscate the data and de-identify it, but there are scenarios where you could re-identify the information if you tried hard enough. So it helps us, in terms of limiting access to it internally, but it's not something that we would want to make freely available.
And on the implementation guide, is that something you all publish to the networks?
Yeah, those are, to the best of my knowledge, those are all on our website as implementation guides for our documents.
Okay, so maybe that's would be helpful. I don't know if Mike or Craig has seen them before. Is that fair to say?
We've not seen payer-specific ones, but we certainly have gone through X12 implementation guides to get a sense for what's coming here. And we did it last year with the pilot as well.
Okay. Okay, any other, I think Joe or Charmaine, any comments from the payer perspective?
Sure, this is Charmaine. I would say that from the United Healthcare perspective, currently the infrastructure for this type of data sharing doesn't exist currently. So I think, as Angela mentioned, those technical specifications would be really important for the payer to have a better understanding of where the needs are, what resources would be necessary in order to build this infrastructure to meet the state's requirements. So I think, the good starting point really is to have those tech specs and share it with payers for payers to be able to react to.
So Charmaine, that brings up a kind of a different point. Would it be more useful if Chris took a publicly available implementation guide and framed out what they thought was relevant and asked the carriers asked the networks for input on that as a set of structure, or working with the networks to develop that?
Certainly a good question. In terms of developing this implementation guide, I really think it's more of indicating what the state is actually looking to receive and how that information is going to be shared back, like the purpose of this information. Because in our first meeting, for example, there seemed to be more of the impression that providers would have some of the data and insights that were coming out of this project. But now it seems that providers wouldn't really be getting any insights from this project. So just having a better understanding of the purpose for the requirement for payers to share the data with Chris, and how that, and exactly what methodology would be needed to share each specific data element that's being requested. So I hope that helps.
Yeah, I think it does. And to clarify, so what we did was, with the input of the providers, honed in on an area or a suite of use case opportunities. And then we backed out a step and said, well, now how do we do this to test the data flow, test that implementation of a transaction between the network and Chris in a de-identified manner. So the value to providers is at least in this first step of testing on a potential use cases, is more for public health in a focus area of, in this case, diabetes, with the notion that once the data is able to move back and forth, there would be more specificity around a use case and how that might look. So last time we talked more about the structure of a use case, and this time we really wanted to dig into more of how the data might start to be, called out, and how it would move between these two organizations, because there's, wherever we land, there's still a good bit of testing on the data flow and being able to establish that those, we'll call it the infrastructure pipes, in order to begin to look at data that's either de-identified or, as we heard our friends from Care First talking, synthetic data for the moment, in order to test the ability to be able to move information. I think we've heard Chris say that, getting as much as they can to help in terms of data content to test is going to be very important as a key first step.
Yeah, and again, I would say that having the outline of what exactly the state would be looking for would be important for payers to also be able to review from a legal perspective what they would be able to share. Again, there are lots of different members to consider. There's the whole, you know, issue around HIPAA, certainly, but also the issue around members that opt in and opt out from the various targeted zip codes. So there's all kinds of things to consider also from a legal perspective before really payers would be able to do anything with regard to constructing this type of interoperable solution.
Yeah, so again, not to skip over the policy questions or comments, they're all very important and we greatly appreciate it. We are, we realize that there's some tackling of policy that has to occur, but there's, with or without the policy components, we've got to create, it gets back to that chicken and the egg aspect. We definitely need to have an infrastructure of pipes, if you will, that can support whatever data that might move. And because networks and HIEs are very different, being able to figure out what that looks like and try to figure out what's needed to make that work is equally as critical. And so that's an area that we really want to try to focus on as much as we can during this call today, but not dismissing your points whatsoever. They're very valid and appreciate your comments.
David, good afternoon. This is Kathleen Loughran at Workgroup, which is one of the, for others on the call, Workgroup is one of the larger MCOs in the state of Maryland. And I have to agree with the comments from the previous speaker. I believe her name is Charmaine from United.
Yes.
And I'm not interested in pursuing policy discussion here, but I think she's raised some good points. And particularly in the Medicaid space, you have a lot of the same data that's collected individually by MCO, but also collectively by the Medicaid program. And it would be important to create parameters that remove the opportunity for duplication so that the numbers are not skewed or the information is not skewed. And it may be that certain requirements for the protection of privacy or release of information would be slightly different between Medicaid and other areas. And I don't hear the Medicaid program in this discussion. So that would be another payer potentially that certainly the MCOs would want to coordinate with, or at least be respectful of, when determining what and for what purpose we're providing data.
Yeah, and so good points. Thank you. As always, we very much appreciate your input. I think the way we would be helpful to keep in mind that there's claim data that's reported by the carriers under many states have APCDs and requirements around reporting to those APCDs. Maryland is one of them, and it does collect Medicaid data and it does collect information from the carriers on a quarterly basis. And that is very useful. And that information is one would consider more of a retrospective view. And what the statute really looks at is how information can be, how we can be more creative around data in flow, meaning that a patient goes to see their physician and the physician sends a claim or an eligibility inquiry to the carrier. And what can come from those kinds of transactions, you certainly can't use them for financial purposes, but you could look at them as trigger alerts for public health situations, or trigger alerts for care delivery issues. And that's really where we've tried to stay somewhat grounded on But I think you bring to light, again, part of the good policy conversations that we will need to take on. Again, and it also goes back to where do you really start, right? I mean, anywhere you land, you gotta be able to think it through and figure out what's needed. And while at the last call, we somewhat framed up the type of information as a triggering alert for the providers of public health, here we've tried to go, okay, let's look at data flows and what does that look like? And you all have been giving us a lot of really good information on that today. But you're absolutely right. These kinds of questions still have to be addressed. So they're on our list of things to get to. And that's the value of having so many really talented people on this work group, because they can help guide us through these complex conversations.
Yeah, David, just not to interrupt, but the sooner we get to some of those questions, makes it easier for me to have the right people from AmeriGroup answer some of the questions that were raised earlier on the really technical components of this conversation, right? Because I'm probably not the best qualified, but the people that work in these systems with our claims and other data really would be qualified to speak to what would or wouldn't be comfortable based on what you're trying to do.
Yeah, that's a good point. Fair enough. Thank you for that.
Yeah.
Angela, your comment.
Sure. And I appreciate the state taking sort of a thoughtful approach with a pilot and testing a proof of concept. One thing that I would recommend that is still a bit of fuzzy gray area in my mind is that if we're testing the data flow, testing the proof of concept, what are actually the outcome goals that we hope to achieve? What are we actually testing so that we know, were we successful in X, Y, and Z? And I don't think that's sort of laid out, so we know after the test is completed, okay, yeah, we did a B+ job, or we did a C+ job. So I think having those details would be helpful as well.
Okay, I think that's probably one of the easiest questions I think we can answer, and maybe I'll ask Mike or Craig to jump back on, because essentially it's the flow of data. Does it how does it come out of an EHN? What's the frequency of it? Is it set to occur on an automated basis? Is it a manual push? How does it get to the HIE? What's the format? How does it get ingested? And what's the frequency? And I think it's the looking at it from data out to data in. And I think we get a B job if it can happen seamlessly. We probably get a lower score if it requires a lot of manual intervention. And we'd probably want to be able to, as we think through about data flow, we'd want to try to resolve those kinds of challenges, because a more automated approach is certainly a better approach. Mike or Craig, can you comment here?
I think you laid out the exact thing we would try and do. We sit down with our pilot program partner and figure out, understand each other now, and the implementation standards, whatever, where should it flow, how should it flow, and that's our pilot. And then we hit a button, and if it works, that's a B. If it doesn't, that's something lower. Yeah, exactly what you said, I think. It's an end-to-end test.
Very well put. Angela, does that help a little bit more, or does that still create?
No, I mean, I think general overarching, I understand sort of the goal, move data from one point to the other. I think what are sort of the matrix of success, I think I hear you say in terms of, is it a lot of manual process as well? What is a lot? What is considered a lot? And I think those types of details would be helpful, because at the end of the day, we have to say, well, this wasn't successful because we were hoping to achieve X, Y, and Z.
So would it be better if we had a subgroup of the technical folks from some of the networks, some of the electronic health networks, sit down with with Crisp's technical team to talk about how this might work. And we would be happy to be a part of that to facilitate the conversation. Is a subgroup what you're thinking might be most useful, Angela?
I mean, I think a subgroup could help to figure out what those metrics of success are. However, I don't think, I think to Kathleen's point is it's hard for the technical folks to speak to that sort of capabilities without addressing the policy. So I don't want to bring up policy again, but I think it's hard to pull apart the two.
Okay. Other comments as it relates to what's been discussed or talked about and from the group today? So talking about technology is not, it can be a bit difficult because the technology skills vary across the landscape of workgroup participants. It would be ideal if we could continue to set aside the policy discussions in hopes of being able to move forward in figuring out what the data transmission would look like. So I would ask that the networks give that a little bit more thought, because we're not expecting data dumps of 837s at this stage, but what would be helpful to know is what can flow and how end-to-end testing might look. And we will get to the policy pieces that you all have raised, but even if we just talk about what the structure might look like, and without yet as a next step pushing any buttons to have the data flow, but being able to talk about the structure would probably help advance the work a bit. Could I encourage Angela, for the folks from Change Healthcare, to be willing to engage in that kind of conversation?
Yeah, I mean, we're here to engage in the technical discussion, the policy discussion. We're at the table.
That's wonderful news. And Kathy, how about you all at Availity? And I think we might have lost her. Okay.
Yes,
Availity
is also here.
Oh, yes. So go ahead, please.
No, we're here to to discuss how this is going to work. I think Kathleen brings up a good thing about the duplication, because like both Change and Availity would deliver claims for AmeriGroup from our providers to AmeriGroup. So that is a big concern too, since basically we consider the payer, the provider, as the source of the data. So we'll have to figure out how that duplication gets figured out.
Yeah, those and I think that's part of what I heard Angela saying. We have to look at the technology and look at where the technical components lie and how would that end-to-end data flow. And I think that's clearly what I heard Mike talk about in terms of Mike Fierro and Chris. Just being able to say, yeah, data can flow is going to be a huge accomplishment in any use case. So even if the data we use originally is more synthetic, that would work as well too. So what I would propose as it relates to the technology piece is that we'll work with Mike and Craig to see Angela and Kathy, who we could reach out to within your organizations, that we could engage in a bit more of a technical conversation. Does that seem like a reasonable next step to everyone?
Sure does.
Okay. So we have hit upon the large areas of conversation for today. And we've done this in about an hour. So I think that the takeaway as a next step is to sit down and talk more of the technical aspects. And those kinds of discussions are, of course, open to everyone in the work group and, of course, the public, because our meetings are. But we'll reach out to the group to see if there's anyone who has interest other than the technology folks, and welcome them to participate. So let me invite our executive director, who has been part of this conversation, to weigh in here.
Thanks, David. I apologize. We have had a security incident at our office. Don't mean to frighten you with that, but we've had security people here. So I've been in and out of this meeting, but I think I've captured the flavor of it pretty well. And I want to first of all thank everyone for coming in virtually on a Friday afternoon to share their thoughts on it. But I did want to remind everyone that we're trying to develop a pilot here. Keep in mind that there is a broad preemption or exemption for public health data use under HIPAA. The HB 1022 passed last year spelled out that this particular vision was for public health. The agencies that were spelled out were the Department of Health, HSCRC, and MHCC. So I think those questions need to be put aside as we think about what would be an appropriate use case. But we are, as mirroring what David said, doing this in a very, very limited way with a limited data set to make sure it's a viable opportunity from the standpoint of public health officials. Is this of any value? I think we heard from some that raised good questions about, well, could this potentially duplicate information's out there, or potentially another concern, conflict with already trusted information. Those are both things that need to be examined. You're not going to necessarily be able to tell that if you pull off a dozen or so ICD-10 codes, but I think this is a good place to start. And I just plead with you to give us a little technical leniency. And as we move forward, this is not the end point of this entire initiative. It's an appropriate feasibility step to, as Mike and Craig both pointed out, to test the data flow without raising a whole host of other issues with a significant data request at the very outset. So just I think step back and think about this as this is a test. Feasibility of concept is where we're at this point, and we trust that the next meeting will come together with some good technical issues to wrestle with. But I appreciate more than anything else everyone's thoughtful questions this afternoon. Pass it back to you, David.
Thanks, Ben. We appreciate the input and observations. So we are ahead of schedule by 20 minutes today, and I would ask if Melanie can talk a little bit about next steps, and then I'll say a couple things and we'll adjourn for the afternoon.
Okay, thank you so much, David. And I did want to ask at the beginning of the meeting, there's a couple people on the phone, if they could just identify themselves. I saw 8637, I believe that's Clay House. And then there was also someone who comes up as 10047277. If you could identify yourself. And then someone with 989 area code.
It's David Bly, that 10047277, I think. Does that look right?
Oh yeah, thank you, Dr. Bly. Thank you very much. Yeah.
Yeah.
I don't know, it just comes up as a number. Maybe it's your ID number. I don't know.
Yeah, I'm on by phone and by the computer.
Okay. Great, thank you. And then someone with a 989 exchange, if you could identify yourself, please.
I believe that's Adrian Ellis.
Oh, okay. Okay, great. Thank you so much. So for the next steps, the recording of this meeting will be posted to the MHCC website, as well as the meeting materials, and we will have a high-level summary up there within the next week or to 10 days. So I think that's it, David. We'll be reaching out to people to schedule the meeting, the subgroup meeting or the smaller meeting that he talked about. So back to you, David.
Yeah, thank you again, everyone. It's great to see you all, and we absolutely appreciate your input. We will be in contact with Angela and Kathy regarding some technical contacts. We'll work with Mike and Craig to coordinate a smaller virtual meeting where we can get things started in terms of what it takes to test. And then we'll bring that back to the larger group to keep you informed. And if there's anyone who would like to be a part of the subgroup, the technical subgroup, just let us know and we'll make sure to include you on the invites. We wouldn't want to leave anyone out. And with that, again, thanks everyone. And we wish you a wonderful weekend, and keep the bottle of sunscreen next to you on Saturday or Sunday. I hear the weather is going to be into the 70s, so you may need it. Have a great weekend, everyone.
One comment, David.
Yes,
Tell
sir.
some people to wear hats. You know who you are.
There's Mike. Take care, everyone. Have a
Thanks,
great
all.
weekend.
Have a great
Bye now.
weekend.
Thank you.